All right, so I get the pleasure to introduce the next segment of this course. My name is Vanessa Monahan, and I am a global director of marketing at Boston Scientific, and I'm responsible for ERCP and EUS devices. So on behalf of my colleagues at Boston Scientific, I'd like to thank the course directors for putting together a really best-in-class educational event, and I'd like to welcome all of you to the BSC-sponsored symposium. During this first-of-its-kind presentation, a multidisciplinary group of experts sitting right here to my left will share their experience and expertise in existing and also emerging techniques in the treatment of acute cholecystitis. At Boston Scientific, we believe that a multidisciplinary approach is necessary for the treatment of these patients, and deep collaboration between the surgeon, the interventional radiologist, and the gastroenterologist is the best for the patient. And as such, we take pride in developing breakthrough technologies that support that multidisciplinary approach. Whether it's SpyGlass Discover, our ERCP devices, and more recently, our EUS Axios technology that is cleared for that indication outside of the United States. So with that, I'd like to introduce our panel of experts. The session will be moderated by Dr. Cheyenne Beredarajulu, and here joining him, we have Dr. Paul Fockens, faculty of the event. He's a chief and professor of the Department of Gastroenterology and Hepatology at the University of Amsterdam in the Netherlands. Dr. Takao Itoi, professor and chair of the Department of Gastroenterology and Hepatology at Tokyo Medical University in Japan. We also have Dr. Pablo Arnoletti representing the surgical group. He's the chief of surgical oncology at Orlando Health here in Orlando, Florida. And last but not least, Dr. Ahsun Riaz, associate professor of the Department of Interventional Radiology at Northwestern University in Chicago. So without further ado, I'll hand it over to you, Dr. Beredarajulu, to kick off the event.
Thank you. So this is a GI audience, and there are a lot of things about cholecystitis that we don't know. And I was preparing for the symposium. I realized I didn't know a lot of things. So I'm going to give you a 5-minute brief overview on acute cholecystitis, and then we will get on to the discussion with case presentations. So by the Tokyo guideline, cholecystitis is categorized into mild, moderate, and severe. Mild is when you have minimal symptoms. Moderate is when you have your leukocytosis with a palpable gallbladder mass, and the patient has got systemic inflammation. And severe cholecystitis is when you have organ damage. When you've got mild acute cholecystitis, the recommendation is to have an early cholecystectomy. It can be done electively unless the patient has got severe comorbidity. If you've got moderate acute cholecystitis, they're usually in the hospital and you need to perform an urgent lab chole. The exception is if you've got a Charlson comorbidity index that's high or an ASA class more than 3, and if the patient's condition is poor, they can have a percutaneous drainage followed by delayed surgery. If the patient has got severe acute cholecystitis, you have to read between the lines. What the Tokyo guidelines tells you is they can have an early lap cholecystectomy if you've got an expert surgeon. If there is no jaundice, there is no neurological or respiratory dysfunction. And they recommend percutaneous biliary drainage in every other patient with high comorbidity or if they are jaundiced and have neurological or respiratory dysfunction. The time to surgery after percutaneous drainage, this is important, 4 to 6 weeks. However, with this background, now we are seeing a lot of these studies. This was published by the Hopkins group that reported similar efficacy between EUS guided gallbladder drainage with the lumen-opposing metal stents compared to percutaneous drainage. And if you look at the inclusion criteria, they tell you any patient aged 18 or more who was deemed a non-surgical candidate. So this is a very loose criteria. And they go on to say that this is a great technique, and compared to percutaneous drainage, you have fewer interventions, shorter length of hospital stay, and therefore should be preferred over a percutaneous approach. They recommended a randomized trial, which was conducted by the Asian group, which is a multi-center study that originated from Hong Kong. And they tightened up the inclusion criteria. Older patients, ASA class 3 or greater, higher Charlson comorbidity index, low Karnofsky scores, and they went on to reaffirm what was said in retrospective studies, that this is a good technique which could be a potential alternative for percutaneous cholecystostomy tube placement. Finally, the Tokyo guidelines in 2018, which was authored by Dr. Itoi, tells you percutaneous transhepatic gallbladder drainage is a standard method for surgically high-risk patients, and when available in high-volume institutes where procedure is done by expert endoscopists, we have the option of EUS-guided gallbladder drainage, and this was affirmed by ESGE, where they tell you with grade A evidence that this could be a preferred technique for high-risk patients instead of undergoing percutaneous drainage. This graph is very, very important. If you look at this graph, this was actually shared by Dr. Riaz, and it tells you that in the United States, over the last 20 years, the rate of cholecystectomy, laparoscopic, has increased by 3%. Open cholecystectomy has declined, but percutaneous cholecystectomy has increased by 567%. So this huge volume of patients, are we going to drain them all using EUS guidance as an alternative to percutaneous technique is important, because I feel this is where our discipline is moving, and there has to be serious word of caution before we proceed in this path. Now I can go on and present 3 cases that we had treated, and after the case, we will ask our panel what they think. The first patient is a 72-year-old female. And before I present this case, I want you to use your QR code, because there is going to be your audience response and you can choose your answers. So just take a minute to scan the QR code if you have not downloaded the app, so that you can participate in the option plan of action. So this is a 72-year-old female patient who presented with acute cholangitis, and the patient was very hypotensive in the ICU, requiring IV pressure support. She was started on IV antibiotics, moved to the ICU. And if you look at the Tokyo criteria, this patient had moderate acute cholecystitis, ASA class 4, Charlson comorbidity index is high, patient is hyperbilirubinemic, the white cell count is 23.6 thousand. You have 4 options. Would you recommend urgent laparoscopic cholecystectomy? Would you recommend a percutaneous cholecystostomy tube placement by interventional radiology? Will you recommend EUS-guided gallbladder drainage, or will you just manage this patient conservatively? So let us go to the audience poll to see what our delegates think. Can you pull up the poll on the screen? It's coming up. It's there. Okay. So, okay. Okay, we can stop the poll. So we're looking at 50%, about 49% for percutaneous cholecystostomy, a roughly equal number for EUS-guided gallbladder drainage. And I'm going to play the video, and this is the video of the patient in whom we performed this procedure. So you can see a nice distended gallbladder. You got some sludge. There are a couple of stones that are floating. And the placement of lumen-opposing metal stents in acute cholecystitis is pretty easy and straightforward, like a pseudocyst. I do not put a double pigtail plastic stent to anchor it. This was drained somewhere from the stomach at the pre-pyloric region. The patient did good. Just a couple of tips. When you drain the gallbladder, if you don't see the gallbladder very well, and if you're going to push against the antrum to gain access, be careful. You're much better off draining through the duodenum, because once you deploy a lumen-opposing stent and the gallbladder decompresses, it will peel away from the gastric wall and you will end up with a perforation. So just be very careful that you're not pushing it aggressively so that you can drain it from the stomach. So that is one. And you can see in this particular case, you see a U-shaped Yoko endoscope to avoid the problem from the duodenal bulb. The second is, don't inject too much contrast. It can flare up sepsis in a sick patient. If you inject contrast, usually there is no need to. The second is, if the patient doesn't get better within 24 hours, you need to think something is not right here. Generally, they do very, very good. You have to suspect a gangrenous or a perforated gallbladder, or your LAMS may have a dysfunction. The lumen may be clogged with stones, and you may have to put a plastic stent. Now I'm going to go back to the case. The patient did great, was discharged from the ICU within 2 or 3 days, went home, continued to have right upper quadrant pain. So the primary care doctor who saw the patient referred her to a community general surgeon for a laparoscopic cholecystectomy. So what was considered a laparoscopic cholecystectomy turned out to be a 3-hour surgery, and the patient was actually not for 8 days, was in the hospital for 18 days. And when they opened up that patient and they tried to mobilize the gallbladder, things spilled into the abdominal cavity. You can see eventually the gallbladder was removed, but not completely. They did what you call a subtotal cholecystectomy. You can see the LAMS, you can see corn that we eat into the gallbladder lumen. And then this case was presented in the M&M, and we were told, well, this patient should have been even treated by an endoscopic approach. So this is, now I want to stop here and ask our panel. Probably we should start with Dr. Riaz, who's an interventional radiologist, what he thinks about this particular technique that we adopted, and should this patient have been treated by an IR-guided drainage.
So first of all, this is a great case. I think it kind of shows what has been the practice at most institutions across the country. If it presented to Northwestern, for example, and the patient was not deemed a surgical candidate at that specific point when they presented to us, we would place a percutaneous cholecystostomy, and then move through this algorithm that we've created at Northwestern, put the cholecystostomy in, and reassess in 4 to 6 weeks if they are surgical candidates, because sometimes their condition which makes them a surgical candidate or not a surgical candidate is reversible. And then, if they are deemed surgical candidates at that time, send them to surgery. If not, then we do some advanced procedures that we've started, not only at Northwestern, but at least 5 or 6 big academic institutions like Hopkins, WashU, where we go in, put cystic duct stents in, similar to transpapillary stenting that GI does, with a good success rate, similar to what the GI success rate is quoted around 90%. And then also do lithotripsy and take the stones out. And I'm not sure what the long-term benefit of that is. We don't really have long-term data on that, but that's a great thing to study as time goes on. And then if we cannot cross the cystic duct, then our GI folk come in and do a LAMS. I think the question comes in patients who are ever going to be surgical candidates. I think that's where the debate will come up. If they are not going to be surgical candidates, LAMS is a great option, because that makes you feel that you're going to be able to put something on inside the patient that will not cause them pain, not have leakage around the drain, and lead to a lot of the grade 1 and 2 complications that Drac talked about. I think if you compare the grade 2, 3, 4, and 5 complication rates, they're similar between LAMS and percutaneous cholecystostomies. I did a Fisher-Sexact test a few days ago about this, using that data from their paper. But the grades 1 and 2 are really different because pain, leakage, as you would suspect from a drain coming out the skin, is much higher. So this is our algorithm, and it's not perfect, but we've done this a lot now. In more than 26 patients, we've done the percutaneous cystic duct stenting and lithotripsy, and have really had really good success rates.
I'm going to challenge you with, you're talking about Northwestern.
I'm sorry?
You're talking about Northwestern, which is an academic institution. You got a great interventional radiology. A majority of cholecystectomies happen in the community setting.
Exactly.
Out in all the rural places. Our interventional radiologists in most of these places can get a drain placed, period. They are not going to go upsize the drain with a cholecystostomy tube and then extract the stones out and push. Not happening. That is real world situation. And there are many patients who can come to large centers for this. And in fact, I had a patient who I saw who had a drain placed August 15th, 1987. And I just looked at it. This guy has been with the per drain for 41 years, just getting it changed. So the quality of care and the expertise are very different across the country. Paul, words of wisdom on what you think?
What are my thoughts on?
What is your thought on this patient? Because this patient came to us very sick. The patient was in the ICU, acute cholangitis, and I was told by the surgeon, yep, we're not going to operate, very high mortality. Please go ahead and treat this patient with endoscopically. We did the treatment. Patient got better very fast, and then now the surgeon couldn't take that gallbladder out, and we landed up with this problem. So, is there a different approach you would have adapted for this particular patient if somebody had called you?
Yeah, well, I think there's a couple of things that are important. If you want to do it endoscopically, if you want to drain if you want to put an axial stent probably endoscopically, and the patient needs to be sedated, or maybe get general anesthesia. So if the patient is too ill even to undergo anything, then of course you can just do a local anesthetic and put a drain in. So I don't think everyone should have, there's no one that should get actually percutaneous drain, definitely not. If you can do it endoscopically and the patient can be sedated, not necessarily intubated, depends a little bit on your anesthesiologist what they want. It is a relatively simple procedure, the acute thing. There's a couple of exceptions, of course. If there's a perforated gallbladder on the ultrasound, then there's nothing we can do, and of course there's a percutaneous drain is the way to go. But otherwise, if you can put an axials in, let the patient actually get better a little bit. Look at the stones, the number of stones that are at the end. If there's a lot of stones in it and they're all small, you can probably put a 10 millimeter in, but you should measure, it takes maybe a minute more, measure the average size of the stones, because if they're like 10 or a little bit higher, then you would put a 15 millimeter in, so because you want to think about the next step already. And if you can do without a drain, of course, that in the end, everyone will prefer that. And that means that the after sales has to be good as well. So you can save the patient in the middle of the night, but you should carefully think of what you're going to do next. And that means, in principle, in about 4 weeks, you should remove the axials, take the stones out if they're there, and place pigtail drains. I think the patient can still be operated on then, but in principle, we will only do this in patients that actually are non-surgical candidates, and we expect them also not become surgical candidates for the endoscopic options, US guided.
Dr. Arnoletti, what is your thought for surgeons? Is this, yep. There are two questions for you. Transgastric stent placement versus transduodenal stent placement, because that will have major implications for your surgery. And two, general surgeons, for all practical purposes, do only 2 surgeries, gallbladders and hernias, right? What does your community think about this?
Well, I have a lot of respect for the general surgeons who are in the middle of the night, sometimes in a small hospital with limited resources, and can need to take care of these sometimes very ill patients that show up unexpectedly. We often refer those patients, oftentimes with a percutaneous cholecystostomy that has been there for a very long period of time, but then they say, well, we're not going in there to try to take the gallbladder now. We'd like to refer to another center. I think the issue with these patients is the decision, is this patient ever going to become a surgical candidate?
Yeah.
And that can be difficult to decide. And I think the Tokyo guidelines provide some suggestions that the patients with jaundice, such as the patient you presented, the patients with a neurologic or respiratory system failure, those are tough system failure issues that makes me lean towards favoring endoscopic or percutaneous drainage. Now, there's other patients that have cardiovascular or renal dysfunction. Those can get they can get better very quickly, and then they could undergo laparoscopic cholecystectomy at the same admission. Now, the issue you were, for us, an opening in the stomach or in the duodenum typically can be primarily repaired and is not that big of a deal. Now, this cholecystectomy in particular may have been very difficult no matter how you drained it, percutaneous, endoscopic, or no matter what. In general terms, the stomach is far more forgiving for closure of the defect and can be handled much easier than the duodenum. The duodenum, as you all know, is unforgiving. The mucosa can evert, extrude. A small hole can cause a lot of problems, particularly if it's friable. Usually the ones we've seen is not that much of an issue, but it can. So to us, surgeons, the challenge is this patient ever going to become a surgical candidate? And if that's the case, then we lean towards, in the correct indication, towards a brief percutaneous cholecystostomy, and then taking the patient to the operating room sooner than later, because the patency rate, not in skilled hands, but in the general hospital, the cholecystostomy tubes, they don't work well, they don't last long.
So one of the things that the surgeons have asked us is, will a smaller caliber stent help? They were asking us, well, can you just put on a 7 French or an 8 French? You just need to decompress it, and when you take it out, that fistula is going to close. Do you really have to use a wide bore lumen-opposing metal stent in these patients? So Dr. Itoi, what do you are one among the authors of the Tokyo guidelines. Do you think we should develop a dedicated stent for this particular indication that is small caliber, or are we on the right track doing what we are doing now?
For me?
Mm-hmm.
So it's quite different from pseudocystic drainage or one drainage. In case of the global drainage, the double pigtails caused by leak or abscess rate surrounding area of the stent. That's why, so basically, gallbladder and the duodenum or stomach are very separate. That's why, so if possible, we want to use lumen-opposing stent lamps to avoid the unnecessary leak or abscess rate after placement of stent.
Do you think we should use a 6 millimeter or an 8 millimeter stent and not a large caliber stent?
Actually, it's okay. In case of the lamps, 6 millimeter just drainage, much better. But in case of the lot of stone, at that time we use 15 large bore, because after that, after placement of lamps, we remove the stone after that, after the resolution of the inflammation.
You remove the stone endoscopically.
Yes.
The problem is, about 25% of patients, whether you do a percutaneous drain placement or a endoscopic internal drainage, have biliary type pain. They complain of right upper quadrant pain, they've got some nausea, it's a vague symptom, which is what happened to this patient. So I don't know whether just removing the stones from a gallbladder will make them feel better. My take is, as long as that gallbladder is there, they've got some sort of a chronic inflammation and that pain persists in those patients. So just leaving a double pigtail plastic stent and taking those stones out may resolve the acute illness, but I do not know whether it will resolve the underlying symptoms.
So I have a good, I read this paper recently, where even after a cholecystectomy, they have a 15% rate of post-cholecystectomy syndrome, where patients continue to have pain in the right upper quadrant, and sometimes that is being, there's an actual anatomic issue which GI can take care of, like a stone in the CBD or a leak but a lot of the cases, they don't have anything wrong. They just have that continuous pain. So you're right, there might be some degree of inflammation just in that liver gallbladder fossa that leads to them having continued pain even after something like a surgery is done, where you would think that if they've taken their gallbladder out, nothing can happen after that.
Paul, you're...
Yeah, I think we're typically, ideally, you just take the gallbladder out. I think there's no discussion about that. So if the patient is temporarily not so fit and will be fit, so the gallbladder should come out. But you saw nicely the rise in the incidence of percutaneous and also now endoscopic drainage is that we have an aging population, multimorbidity, etc., and they become less and less attractive. So I think as gastroenterologists, as interventional endosonographists, if that exists, we have to make sure that someone is on call for this. If you want to provide a service, it's 24/7. This is not the patient with a biliary stone that can always wait until tomorrow and quite often 2 days, etc. These are the patients you have to be willing to come in for. So that means, I'm not sure how many people will do it. In your case, maybe 5, in my case, maybe 3, but someone should always be available for this. You can't offer this as a temporary service when I like to do it on a Saturday afternoon or so.
I think that's a very, very fair statement, because the interventional radiologist is always on call.
Exactly.
Whether we would want to place a gallbladder stent at 2 a.m. in the morning in the emergency room is a little bit tricky.
And we have a tendency in gastroenterology, of course, most things can wait until tomorrow morning.
Sure.
Almost close to everything. Most GI bleeds, etc. So
Can be. So I thought, I think it's very important to provide some sort of a guidelines. I think the high-risk surgical spectrum is a very big spectrum. It goes from one, and it's in the perception of what we think is high risk. I think rather than use the word high-risk surgical patient with no time frame, we should have something called a never surgery patient. And this guideline or some consensus should be developed on a patient who will never go to the operating room. At the middle of the night, they look very sick. And then once you place in a stent, they get better. I developed some, I did a little bit of reading to figure out, particularly for you, Dr. Arnoletti, are these never surgical patients? If you've got severe COPD, irreversible pulmonary hypertension, cirrhotics with portal hypertension, end-stage cardiac disease who will not get a transplant after age 70, malignancy like pancreatic cancer, we see this all the time. You put in a covered metal stent, gallbladder is distended. I don't think there should be a problem in putting LAMS in these patients, because more than likely they will not have surgery, and obviously anybody with severe nervous system problems. Are we headed in the right direction, developing a pathway for these patients? Is this a checkbox that any gastroenterologist can look and say, yep, we can agree with this, let's go with the LAMS, or you will not be comfortable with any part of this?
Very good, very good. So your categories, the non-candidate, generally the non-candidate surgery patients include relatively non-candidate and never surgery. So it's sometimes excuse for the endoscopist. Endoscopists want to do LAMS, to use the LAMS, so this is a non-candidate, but really not so. Sometimes very candidate, and so we need to move the surgery. We know a lot of such kind of patient, so we have to divide it into the never surgery or non-candidate surgery.
Correct. Never surgery. I think it's easier said than done. But I think we need to start thinking on these lines, because we are going to land up with a lot of these patients that we will be seeing. And obviously, as you know, there's always litigation is a problem. This can be a medico-legal issue that is going to be knocking on our doors sooner or later. And the other question I have, I know for pseudocysts, we take these stents out in 4 weeks to 6 weeks because there's a delayed bleeding. And obviously that the place where we place the stent, you got the lesser sac, you got all these vasculature that can bleed. Inside a gallbladder, I don't think there's a problem, except food going in. I don't anticipate anything, and I don't think food going in is going to make patients very sick as long as the lumen is open. But we don't have any data on what happens to long-term LAMS inside the gallbladder. Is there anything that you know, Paul, that we don't know about indwelling LAMS in a gallbladder?
I think they should come out after 4 weeks. I think it's not going to go well if you keep them in for years, for sure.
I try to dig out this information to see what is published out there. So the long-term adverse events, there was only one paper had looked at it at 9 months, and it was about 7%. There's another paper that came from South Korea looking at about 84 patients, and then they tell us, again, if you look at the recurrence of cholecystitis, it's 6%, reintervention rate 6%. So, and that follow-up was approximately 2 to 3 years. So, despite only these two publications, it looks like recurrent cholecystitis will happen after a LAMS placement in 7%. Recurrence of symptoms can happen in about another 7% of patients. So I think for patients who have a very short survival time, if you think they will die within a year, I think it's okay to leave these stents. But on the other hand, if the patients are going to live longer, if the patient does not want to have a cholecystectomy, like the patient we are going to do tomorrow, and we don't know what will happen, then I think we need to exchange these stents for double pigtail plastic stents or take the stones out. Once again, absolutely no evidence, but just looking at the literature, I think this might be a pragmatic approach until we can resolve this more. Any differences of opinion?
No, I think you said something like if you think they will live for a year or something. We're very bad at predicting. So if it's a pancreatic cancer patient with, you place the metal stent maybe in the bile duct, the cholesterol, etc., then I think it's relatively easy to do it. But especially the frail 85-year-old, we're pretty bad at predicting their exact prognosis. So.
Go on, Riaz.
I had a question for the gastroenterologist on the panel. Once you take the LAMS out, is the fistula going to close? Is that the intent? Or do you want that fistula between the gallbladder and the intestine to stay open?
I mean, the problem is this. Radiologists will always tell us, 4 to 6 weeks, the drain will come out. It doesn't come out.
No. Yeah. I never say
it doesn't come out. They keep changing these drains back and forth and back and forth.
Yeah.
We don't... See, the problem for us is this. We are told, go drain this gallbladder, the patient is sick, nothing will happen, go for it. And then we deploy it. We think, very naively, maybe these patients won't survive for more than 6 or 8 months and they're going to die. So we want those stents to stay in place and we don't want to go beyond that. This idea of taking that stent out and then suturing that and so on, and I read an article in the Journal of Clinical Gastroenterology as I was digging around for the symposium, a transduodenal stent that was deployed for gallbladder drainage, that patient landed up getting a Whipple because of problems with surgery. How did it land from an inoperable patient to a transduodenal drainage up to a Whipple procedure? So this is the challenge. So we have no intent actually to remove it. If you remove it, that's why we are telling maybe we need to exchange it for a double pigtail plastic if the surgeons want to operate, or we need to take the stones out.
So does it matter to you as a gastroenterologist or to you as a radiologist if the cystic duct is patent or not? Whether you decide to just pull the catheter out once you say you remove the stones?
So for calculus cholecystitis at our institution, and I think a lot of the institutions that we are trying to do this now, we do not remove the drain until we have crossed the cystic duct and put 2 double pigtail stents,
and I think that's important, right?
And taken care of the stones as much as possible.
Right.
If we can't do that, we either do a combo procedure with GI where we inflate the gallbladder, because the gallbladder after 4 to 6 weeks becomes really scarred down, really hard for the gastroenterologist to hit once there's a drain in it. So we do combo procedures with them, inflate the gallbladder so that they can stick the gallbladder using EUS. We even use something called Lumason, which is an ultrasound contrast agent to maybe help them sometimes differentiate between the gallbladder and other structures. So if we can't cross it, then no, we do not take the drain out.
Right, because it will not work, right?
Yes, with calculus cholecystitis, there's a few papers on this. If you take the drain out, even if the cystic duct is open, when you do your cholangiogram, there is around a 40% rate of recurrence of acute cholecystitis within a certain time.
So perhaps that can help decide. And I don't know if when you do the LAMS, can you determine the patency of the cystic duct?
Not when we remove the LAMS. Actually, theoretically, yes. If you put on a big balloon, occlude the lumen of the LAMS, and you inject contrast like crazy,
if you're able to remove.
Ideally should go through the cystic duct and fill the common bile duct. Easier said than done. It might be much easier to do an ERCP and show this communication with the cystic duct.
Or use a gallbladder stent, if you cystic stent, right?
Yes,
if you were able to get to it, right?
So I think in the interest of time, I'm going to go pretty fast on the next two cases so that we'll be done in the next 10 minutes. And these are just concept cases. Once again, this is going to be an audience poll, so get ready with this one. This is a 78-year-old female patient that was referred to us with gallstone pancreatitis. Patient had elevated liver tests. She then developed septic shock, developed a PEA, and was pulseless for a period of time, and she was resuscitated. Patient also, during the same hospitalization, had a coronary stent placed, started on anticoagulation, antithrombotics, and we were told this cannot be discontinued for the next 6 months. She didn't really have a severe cholecystitis. So if you look at the imaging, the gallbladder was okay. She was ASA class 3, Charlson comorbidity index was 5, her bilirubin was 1.8, the white count was 17.6. So this is a patient we saw maybe about 2 months back. So what will be the plan of action? You can use your polling. So one, will you do a lap chole? But again, you must know that this patient is on antithrombotics and so forth. Second, will you send them to our IR colleagues? Third option is EUS-guided gallbladder drainage. Fourth, do nothing. Just give some pain medications and see what happens. And finally, will you do an ERCP for transcystic drainage via the major duodenal papilla? So you can make your choices, and let's run the poll.
Something's going wrong here, Chaim.
What is that?
Something is going wrong here. Where is the EUST?
Actually, they're not paying attention. Quite impressed. So yeah, so this was the problem. This particular case, I'll play this. So the problem here was our interventional radiology colleagues told us, listen, this antithrombotic business is a little complicated. We're not going to go put in a drain. So this is going to be challenging. And the cardiologists would not budge. They said, no, you're not doing it. So I thought maybe I'll try an ERCP route, and you can see those stones. I should not be doing a sphincterotomy. I did because I could not get any catheter past, it's like a fulcrum effect through the transcystic duct. I was able to coil a wire, and then I thought, well, if it is going to bleed, so be it. But I was able to get in a plastic stent, and this patient is doing well. She's been discharged, doing okay. So my hope is I'll bring this patient back maybe in about 4 to 5 months, remove the stent and see if she can go for a cholecystectomy. So the thing about this is ERCP is an option in select circumstances. Putting a transcystic stent is no fun. It's a tough procedure to get the wire. You need a good technician to get the wire across a cystic duct and coil it in the gallbladder. So if you do that, this is one good option. I'm going to go to the last case.
Just one question. Can we do the axials without stopping the anticoagulants?
Ooh. Can you do the axios?
I would vote for yes. I think.
It's possible if you're asking about it, because this is not the lesser sag. I would think, yeah.
You burn and you compress, but it's beyond the rules.
Yeah, if not, you can call me.
Or me.
That's right. I would call you.
What do you think? Can you do an axios in this patient without stopping anticoagulation?
No.
No. You took a long time even to FNA.
Okay.
Yeah, I agree with you, Paul. I think so.
It's against the rules, but I think it's not impossible.
Yeah,
and nice that you showed that beautiful cannulation of the cystic duct, but it's not always easy. It depends. There are series that say it's 80% effective. There are series saying it's like 20% effective.
I agree with you.
Firstly, I perform the same ERCP, but I never use sphincterotomy cut. Yeah. And in addition, in order to avoid post-ERCP pancreatitis, you already place prophylactic pancreatic stent. In this case, that's why. So no need of the cut.
Need for it.
Yeah.
I mean, I think the angle was technically difficult, maybe, but a point well taken. It was a double pigtail stent. So, and I'll go to the last case. So once again, you can get ready with your polling. This is a young 14-year-old lady. She came with metabolic encephalopathy, and she had gram-negative sepsis. She also had severe peptic ulcer bleeding in the hospital. Her CT abdomen, you can look at that gallbladder, is acalculous cholecystitis. She had right upper quadrant tenderness, a palpable mass. Her ASA grade is 4 at this point. Bilirubin was 0.9. LFTs are all normal. She's got leukocytosis. So again, the problem here is metabolic encephalopathy with a gram-negative sepsis with ASA grade class 4. What would your plan of action be? Would you do a lap cholecystectomy, refer her to interventional radiology, get an EUS-gated gallbladder drainage, do nothing, or consider ERCP as a treatment option? So we will run the polling now and give about 30 seconds to see what you would do. I think it's about, yeah, we can stop now. I think about 50% of you are right. It's actually a percutaneous cholecystostomy. So we sent it to the radiologist. A drain was placed. Now 6 months later, patient is doing great. And the surgeon who referred the case originally to us was now telling, well, there's a PERC drain. We referred this patient twice to IR and the drain for some reason got replaced. Nothing else was done for this patient. Why don't you do a lumen-opposing metal stent as internal drainage for this patient? They said, so this was sent by the surgical team because of different reasons. And you got 4 options here. Should I listen to the radiologist, to my surgeon and just do one LAMS? It's easy. All that you need to do is to insufflate the drain to distend the gallbladder. You can put a lumen-opposing stent. You just pull out the drain and let's see what happens as a second option. Or should you tell the surgeon, no, maybe you need to find one of your partners to do a cholecystectomy? Or should I check the cystic duct by an ERCP and see what's going on? Or not even take this referral? So these are the 5 options. And
Chime, you mean by number 3, a different surgeon?
different surgeon.
Or a different interventional radiologist. I think like, if the cystic duct is open, Shyam, I would be comfortable in a patient who has acalculous cholecystitis, pull the drain out.
I agree.
If the tract between the skin and the gallbladder is formed and they're clinically doing okay and they have a patent cystic duct with no stones, I think I'm very comfortable taking the drain out.
Do you know what is I mean, maybe I'm reading the literature too much these days. The literature tells us if somebody had come to you with cholecystitis, they don't tell me whether it is calculus or acalculus. If a patient had come to you with cholecystitis and you had put in a drain and you had taken the drain out, 28 to 35% of the patients over a period of 2 years will have biliary type symptoms. So what do we do about that?
I think that's possible with the drain or without the drain, as long as they don't have that repeat situation where they're that sick and they don't have sepsis and they don't get sick enough where they're getting the acalculous acute cholecystitis. I think that pain will happen with or without the drain. Yeah.
I think that's a fair statement. So what we did was, I didn't say no, but I did an EUS exam on this patient before I did anything. And you can see we are flushing the percutaneous drain. So this is an important technique. If there's an indwelling LAMS that nobody's, a drain that nobody's willing to remove, you can decompress it internally. Just flush water and you can drain it. And after I did that, I did an ERCP. I wanted to look at how the cystic duct looks. And we are injecting contrast. And you can see that the contrast is, will soon, if you put in a balloon at that region, and then you inflate that balloon. I wanted to sweep the common bile duct because I thought it will be an appropriate thing for this patient, irrespective of whether the gallbladder comes out or not. And you can see the balloon that is going in so that you can get a good cholangiogram. And you can see the cystic duct is full, the gallbladder is completely opacified. And then we just removed we did exactly what you did, what you asked us to do. We just told the surgeon, we're going to pull out the drain ourselves. I think you need to operate on this patient or do nothing. There's no role for a lumen-opposing metal stent in this particular case. So I think we have addressed pretty much all of these questions that have been outlined here. I thought I'll provide a summary statement. I think it's very important to have take-home message. And I think this may be imperfect with what is coming down the line. I think EUS-gated gallbladder drainage can be performed instead of a cholecystectomy in never surgery patients. We as a group, hopefully in conjunction with our surgeons, will develop some sort of a recommendation on who these patients are. The second is when the surgical risk status is unsure, I think we should just perform a percutaneous drain placement or consider ERCP. I don't think we should put on a LAMS when we are not sure where this treatment pathway is going to send us. The third, I think we should also insist that patients with PERC drain be evaluated by our interventional radiology colleagues within a 6-week period. If they are a surgical candidate, sure enough, they should go for a cholecystectomy. If they were never surgery candidates, and if our surgeon and our radiologists tell us, well, we are not going to do anything, I think it's reasonable to perform EUS-guided internal drainage in these patients. We all need to start collecting data on the outcomes of indwelling LAMS. We have done about 25 to 30 patients. We are about to submit this, but this is good prospectively collected data that you can look forward to. And finally, I think we need to have a good consensus within each institution to determine the role of EUS so that we don't land in litigations, particularly in the United States. I think we should have our radiologist colleagues, we should have our surgical colleagues, and develop like what they have done in Northwestern, some sort of an algorithm so that it is institution specific that we can to manage our patients. So with this, I think I want to thank our panel for staying so late after doing these procedures, and for Dr. Riaz for coming all the way from Chicago for your 45-minute symposium, and to Boston Scientific for organizing this. So thank you, and join us at the reception this evening. Thank you.